will begin then. And first and foremost, I just want to introduce myself. Hi, I'm Hannah Pescaru, and for the 2021 IYRC, I conducted my research on the link between COVID-19 exposure and engagement in body-focused repetitive behaviors. Thank you so much for taking time out of your day to attend. I am so excited to be able to present this relevant humanitarian cause. First of all are some disclosures. If you yourself know that you struggle with one of these behaviors or you have a loved one who does, you might feel maybe a little bothered by the topics discussed in this presentation, or maybe some of the cartoons would bother you, but nothing is graphic, so everything should be okay. To begin the presentation itself, I wanted to go ahead and define what a BFRB actually is. BFRB stands for body-focused repetitive behaviors, and they are compulsive behaviors that involve fidgeting with the body. Some common examples include trichotillomania, or compulsive hair pulling, dermatillomania, compulsive skin picking, and onychophagia, compulsive nail biting. These behaviors are estimated to impact 1 in 20 Americans, and they develop primarily in adolescence. As seen in this cartoon, we have a cartoon man picking at a blemish on his face, which we probably all have done at some point or another in our lives. So I wanted to clear up some common differentiations and misconceptions about what constitutes an actual BFRB. First of all, BFRBs are disorders. They are not bad habits. As said in the last slide, everyone occasionally picks at a blemish or tugs at their cuticle, but there comes a point where these behaviors begin to interfere with one's life, and the psychological damage is unable to be stopped. The patient can't stop. At this point, the behaviors become clinically significant to healthcare professionals, and they are able to be categorized and diagnosed as BFRBs. As previously stated, no matter how much harm an individual may be experiencing, they are unable to stop. So I also want to clarify that BFRBs are not forms of self-harm. Physical damage especially, that is an unintended consequence. It's not a goal of the behavior. BFRBs are actually seen as maladaptive emotional regulation mechanisms, meaning that while they are not the ideal coping mechanisms, they do relieve stress and anxiety and even produce feelings of pleasure in a patient. So they are not meant to cause pain. Here we have a diagram of some anatomical and physiological differences in the brain of an individual with a BFRB. In this blue area here, we have the inferior frontal gyrus. This controls inappropriate motor function and movement, and this is thinner in BFRB patients. In the green and orange, we have the corticobasal ganglia circuit. These corticostrial circuits and the basal ganglia both control inappropriate motor function as well. So at any point on these circuits, if there is damage, it can lead to hyperactivity or abnormal repetition of a certain behavior. This dysfunctional repetition can also dysregulate the brain's reward system. BFRB patients begin releasing dopamine upon engagement of their behavior. So they would associate that behavior with the reward and keep engaging in that behavior in order to achieve that reward. A final difference is this teeny tiny area in pink, the amygdala. The amygdala perceives pain. A study led by Professor John Grant found that individuals with BFRBs perceive pain just as strongly as the controlled individuals, as seen through their MRI scans. However, the BFRB group experienced dampened autonomic responses. So both groups would perceive pain at the same level, but the BFRB group was less likely to do anything to stop that source of pain. So that offers some explanation for why BFRB patients continue their behavior even though it hurts. As previously discussed, it is very hard for individuals with the BFRB to stop their behaviors as they have neurological differences that cause their repetitive engagement, and they can't always receive the support they need. As a result, I was curious to know how BFRB engagement impacts COVID-19 risk. Humans are intrinsically prone to touching their faces 10 to 20 times an hour, but because of these BFRBs, the patients have greater compulsions and they touch their face even more. So I hypothesized that it would increase risk of contracting COVID-19. Vice versa, as BFRBs are seen as maladaptive emotional regulation mechanisms, I was curious to find out how the stress of the pandemic impacts BFRB engagement. It's a stressful time for everyone, so I hypothesized that this increased stress would lead to more engagement in order to regulate the additional stress. In order to conduct this study, I conducted a literature review by surveying articles using PubMed and Google Scholar searches. I used a predetermined set of search terms, including various iterations of SARS-CoV-2, coronavirus, COVID-19, etc., as well as numerous examples such as trichotillomania, dermatillomania, onychophagia, etc., to broaden the category while still maintaining a level of specificity. Disorders were limited to mainly independent individuals, excluding those left on caregivers for basic needs. So disorders such as cataplexy and chorea were excluded. Articles only briefly detailing body-focused repetitive behaviors under a larger discussion of autism or Tourette syndrome, for example, were also excluded. This picture is a picture of the Prisma flow diagram I made depicting the screening of 77 articles and the synthesis of 35 articles used in this study. And now for my findings. Individuals with BFRBs were already identified by Dr. Hofton as being more sensitive to sensory stimuli. And so this can be extrapolated to the fact that there is now a massive influx in scary statistics and information from all these different sources of media. We are already greatly affected by this mentally. However, this can be extrapolated to BFRB patients because if they are more sensitive with sensory stimuli, they would feel additional stress. Furthermore, BFRBs as maladaptive emotional regulation mechanisms are exacerbated by these feelings of stress and anxiety. Logically, increased stress would mean increased engagement in order to regulate that stress. Finally, Dr. Murphy also identified that individuals with BFRBs experienced a longer stress reaction time. So not only do individuals with BFRBs perceive stress more acutely, but they are actually stressed for a longer period of time. So again, greater stress leads to increased engagement. Simultaneously, BFRBs, specifically onychophagia, were shown to transmit infectious microbes, Enterobacteriaceae, from the fingernails to the mouth. Increased time with hands near the face would therefore lead to increased chance of infection. This can also be extrapolated to the current pandemic, as the COVID-19 virus, like Enterobacteriaceae viruses, also remains on surfaces. And other BFRBs, such as trichotillomania and facial dermatillomania, can also then be included as hands are still brought closely to the face, and COVID-19 is more likely to enter through the facial orifices. So to summarize all of the information in that last slide, we have this cycle that the stress of the COVID-19 pandemic leads to increased engagement in BFRBs. But this increased engagement leads to increased risk of infection of COVID-19, which leads to more stress, and the vicious cycle continues. In order to make sure that we all get through this pandemic safe and healthy, prevention methods must be discussed. In general, BFRBs can be treated using a variety of methods. Pharmacotherapy, for example, involves treatment with substances such as N-acetylcysteine and clomipramine, although data researching these substances is limited. Cognitive behavioral therapy, the most common example of which being habit reversal therapy, is proven to be efficient as it works on awareness and substitution skills. For example, an individual with onychophagia would identify his or her personal triggers that get him or her to start biting the nails. However, this individual might begin knitting or sitting on his or her hands in order to prevent the biting. However, during the pandemic, some prevention methods have changed or won't work. For example, again, with the example of onychophagia, someone might apply hot sauce or garlic to the nails in order to produce a bad taste when the fingernails are entered into the mouth. However, this doesn't do anything to lower risk of infection because the fingernails are still in the mouth. We want to completely prevent that from happening. So again, habit reversal therapy would be best in the case of the pandemic, as it would prevent awareness and the contact of face and fingernails. For some closing remarks, I just wanted to say that if you yourself struggle with these behaviors or you know someone who does, you are not alone, even though BFRBs may seem like a fairly stigmatized and new discussion. Especially during the pandemic, you need our help more than ever, and just know that help is available. I'd like to give a big thank you to Mr. Paul Lewis, who was the strongest guide and mentor throughout the research process. Mr. John Kenny, my human physiology teacher that helped me study the neuroscience behind BFRBs, as well as the TLC Foundation for BFRBs, which is the national educating nonprofit. They offered me with professional guides and professional resources that truly helped my research. I'd also like to thank you all for attending and helping make the world a more accepting, supportive place in the process. And we are all struggling, but you are truly helping populations that are very vulnerable. Here are my references. Thank you again for coming, everyone. And if anyone has any questions I can answer, I'd be happy to do so, or at least point you in the right direction. Thank you.
Great. Thank you so much, Hannah, for that wonderful presentation. Does anyone have any questions for her? Type them in the chat, raise your hand. So one of the things I'm curious about is we just had this great talk about social prescribing, right? It seems like there might be an overlap between therapies for BFRBs and this kind of therapy through social interaction. However, there's also this potential counteraction of overstimuli, right? And there's this whole kind of mess of dealing with COVID and not being able to have some of these social prescribings. So I'm wondering if you came across any literature related to virtual interventions specific to BFRBs that maybe were successful or not successful in the time of COVID.
Yeah, I actually didn't include this as a reference, but in my thank you, I mentioned the TLC Foundation for BFRBs because I actually have experience and I've seen that they offer virtual support groups, obviously now during the pandemic more than ever. And those are actually proven to be very successful because they offer support groups for all different ages and you can connect with people close to your age, and it still offers that sense of community and acceptance even during the pandemic. So for social prescribing, I'd really just recommend going to the TLC website and getting involved in a support group.
Thank you. Any other questions? Paul, go for it.
Wonderful job, Hannah. My question is thinking about, also complementing the previous talk, thinking about like physicians and individuals in the medical profession who don't really recognize or acknowledge such things like BFRBs. What do you think physicians should think about or do to learn more about it or engage more with it or provide a better experience for those with it?
I think the most important step would just be to keep an open mind. Like Dr. Bogdan mentioned, right now there is a model where a patient could go to a doctor with personal concerns and the doctor will be like, well, who are you to tell me like what I should or should not do? And I think that really doctors really need to keep that open mind and really hear their concerns. as mentioned in one of my slides, BFRBs are often seen as like just bad habits that someone can easily stop or forms of self-harm, and they don't get the help that they need. So I think it's important for physicians to truly listen to their patients' concerns, as well as do some of their own research. There's not a ton of research on BFRBs as of yet, but there is enough out there for physicians to get a better understanding and help their patients more.
All right, great. Thank you so much, Hannah. That's all the time we have for questions.